Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, will be presenting an article published in the July 2024 issue of Indian Journal of Anaesthesia. It is titled A Randomized Comparative Study of Erector Spinae Plain Block versus Low-Dose Ketamine-dexmedetomidine Intravenous Infusion as Intraoperative Opioid-free Analgesia for Modified Radical Mastectomy. We all know that surgery of modified radical mastectomy is associated with significant pain that needs effective management to prevent stress response and it being converted, acute pain being converted to chronic pain. Opioids are mainstay of analgesic management in these type of surgeries, but they have various adverse effects like nausea, vomiting, pruritus, respiratory depression, and may even negatively impact the cancer surgery outcomes. So opioid-free analgesia has become preferable in the recent times. Erector spinae plain block is a safe and effective technique for blocking pain, while ketamine and dexmedetomidine have been found to offer additional analgesic and sedative benefits with minimal side effects. Hence, this study aimed to compare the efficacy of locoregional technique, that is erector spinae plain block, versus intravenous non-opioid analgesics, that is ketamine-dexmedetomidine infusion for multimodal opioid-free anesthesia in patients undergoing modified radical mastectomy. The primary objective was to compare the total 24-hour post-operative morphine consumption in between the two groups. The secondary objectives were NRS at rest at immediate post-operative period, 2, 4, 6, 12, and 24-hour post-operatively, isoflurane consumption intraoperatively, time to awakening, duration of analgesia, post-operative nausea vomiting score, and post-operative serum cortisol levels between the two groups. So institutional ethical committee approval was taken and trial was registered in African Clinical Trial Registry. The study was a randomized controlled trial which included female patients 20 to 60 years of age of ASA grade 1 to 2 coming for modified radical mastectomy. Patients who refused to participate in the study, patients with mental illness, history of drug abuse, local infection in the site of erector spinae block, coagulopathy, patients for bilateral mastectomy or other surgical reconstructive procedure were not included in this study. Randomization was done using computer-generated random number table, and allocation concealment was done using a sequentially numbered opaque sealed envelope, which was kept with the lead investigator. After randomization, the patients were divided into two groups. Group ESPB that received erector spinae plain block with 20 ml of 0.5% bupivacaine, and group KIT-DEX, where ketamine and dexmedetomidine loading followed by infusion was used intravenously. The ESP block was given by an independent experienced anesthetist. After the patients were shifted to OT, IV cannula and standard monitors were attached, and general anesthesia was induced with 1 mg per kg lignocaine, 2 mg per kg propofol, and 0.5 mg per kg atracurium. After that, endotracheal intubation was done, and anesthesia was maintained with isoflurane with 40% oxygen, 60% air at a rate of 3 liters per minute flow rate. So in the group ESPB, after general anesthesia induction, the patients were positioned laterally and at T5 level under ultrasound guidance and aseptic precautions, 20 ml of 0.5% bupivacaine was given. In group KIT-DEX, after general anesthesia induction, a loading dose of 0.25 mg per kg ketamine plus 0.5 mg per kg dexmedetomidine was given, followed by an intravenous infusion of 0.25 mg per kg ketamine and 0.3 mg per kg dexmedetomidine per hour via 2 syringe pumps. The authors defined bradycardia with heart rate less than 50 per minute when atropine 0.01 mg per kg was given. If mean arterial pressure was less than 60 millimeters of mercury, boluses of 5 mg ephedrine was given. If the saturation was less than 94%, then lung recruitment maneuvers was performed and oxygen inspired concentration of oxygen was increased. At the end of surgery, the isoflurane was stopped and the amount of isoflurane used was calculated by using an anesthetic gas analyzer. After extubation, the patients were shifted to the recovery unit. The time to awakening was defined as the completion of surgery to spontaneous eye movement or response to verbal command. When the patients reached an Eldred score of 10, sample for serum cortisol was taken in the postoperative period. For numerical rating scale at rest, it was numbered from 0 to 100. When the NRS reached more than equal to 40, the duration of analgesia was recorded and rescue dose of IV morphine was given. It was the IV morphine dose was 0.05 milligram per kg of lean body weight of the patient up till a maximum of 4 milligram per dose was given. For postoperative analgesia, IV ketorolac 30 milligram 12 hourly and paracetamol 1 gram 8 hourly was given to all patients. The postoperative nausea vomiting score was recorded as 0 for no nausea vomiting, 1 was for mild, 2 moderate, and 3 severe postoperative nausea vomiting. If the score was 2 or 3, then all patients received 10 milligram metoclopramide intravenous. So the primary outcome was total 24-hour morphine consumption in the postoperative period. The secondary outcomes were numerical rating scale at rest. At immediate postoperative period, 2, 4, 6, 12, and 24-hour postoperatively, the total isoflurane consumption intraoperatively, the time to awakening, duration of analgesia, postoperative nausea vomiting scored at half an hour, 1 hour, and 24-hour postoperatively, and serum cortisol levels between the two groups. The sample size was based on a pilot study of 12 patients at 95% power using a two-sided two-sample t-test with 5% level of significance. It came out to be 64, that is 32 per group. SPSS version 25 was used for analysis. For continuous data, mean and standard deviation was used. And for descriptive statistics, median for the was used for data not following normal distribution. The Kolmogorov-Smirnov test was used to determine the normality of distribution, and the Mann-Whitney test was utilized to compare non-normally distributed data. A p-value less than 0.05 was considered significant. So this is a consort diagram. Here we can see that a total of 80 patients were assessed for eligibility, out of which 8 were excluded because they did not meet the inclusion criteria. So 70 patients were randomized into 2 groups, ESPB and KIT-DEX, where 36 patients per group, and all the randomized patients were analyzed at the end. So this is the baseline characteristic table where we can see there is not much difference between the two groups. The primary outcome was total 24-hour morphine consumption. Here we can see that the ESPB group had a higher morphine consumption than KIT-DEX group, which was statistically significant. For the secondary outcomes, the NRS at various time points, we can see that the ESPB group had higher NRS at all the time points. For isoflurane consumption, ESPB group had higher isoflurane consumption. The duration of analgesia was 0 for ESPB. That means all these patients required rescue analgesic dose at the immediate postoperative period. The time to awakening was lesser for the ESPB group. All these outcomes were statistically significant. The postoperative nausea vomiting score, we can see that it is not much different between the two groups, and for the serum cortisol level was higher between the in the ESPB group, which was statistically significant. So the ESPB group had inferior analgesic properties compared to the KIT-DEX group, with higher postoperative morphine consumption, higher pain scores, and shorter duration of analgesia. This design aligns partially with other studies indicating that erector spinae plane block may be less effective due to the limited coverage of sensory nerve involved in mastectomy pain. Patients in the erector spinae plane block group required immediate rescue analgesia postoperatively, then KIT-DEX group reflecting the systematic effects of ketamine and dexmedetomidine, which have a half-life of about 2 hours. Thus, morphine consumption, need for rescue analgesic, that is morphine consumption, was higher in the ESPB group. The ESPB group patients also had severe burning pain in the axilla than the keto-dex group, which can be attributed to the anti-inflammatory properties of kit-dex, leading to a longer duration of analgesia in that group. The isoflurane consumption was higher in the ESPB group due to need for deeper inhalation anesthesia to maintain the hemodynamic response. The serum cortisol levels that indicates the stress response was also significantly higher in the ESPB group. Limitations of this study can be the less contact time of bupivacaine in the ESPB group patients before surgical incision. Thus, from this study, it can be concluded that the intravenous low-dose infusion of ketamine and dexmedetomidine combined with inhalation-based general anesthesia provides superior preemptive opioid-sparing analgesia compared to erector spinae plane block in patients undergoing unilateral, non-reconstructive, modified radical mastectomy. Thank you.